All right. We're back at it. And here we're going to be talking about OsGood Shlaters condition. Fantastic for us to be aware of. One of my favorite conditions. I've seen this quite commonly in practice. I saw one of the biggest OsGood Shlaters I've ever seen about 2 years ago. This kid came in, could not kneel down on his knee, and his tibial tuberosity looked like somebody's thumb was poking through the skin. We'll talk more about that. Poking behind the skin. It didn't actually break through the skin, but poking behind the skin. So it is a traction apophysitis of the tibial tuberosity. It is literally the quadriceps pulling on the tibial tuberosity so much that the bone remodels due to that stress. So ossification centers in the tibia usually don't fuse until age 16. So generally the person you're going to see with this is under the age of 16. Prior fusion is more prone to injury. Yeah. Especially when combined with repetitive stress with quadriceps contraction. This is usually a fairly active individual. Yes, stretched cartilage matures, ossifies the hallmark and large tibial tuberosities. I do Brazilian jiu-jitsu, and I have a couple of friends who had OsGood Shlaters as kids, and you do not want to roll against these guys because all you feel is that bony prominence grinding right into you. But just quick review of the anatomy. We know that the quadriceps insert onto the patella comes down the patellar tendon, and that all inserts on the tibial tuberosity. And these are big, strong muscles lifting your whole body for squats and jumping and running that can have significant traction and pull on that tibial tuberosity. Approximately 20% of adolescent athletes may be looking at this. Coincides with growth spurts. Absolutely. Boys, roughly age 10 to 15, girls a little bit younger. If you said approximately age 10, you would catch most of your people who are going to be at risk for this. Male greater than female, roughly 3 up to 7 to 1 in some of the research that we've read. So age group, adolescent is a risk factor. What else? Physical activity, high impact sports are your major risk factors. And the treatment actually just really involves modification of the sport activity, which is difficult, especially if they're playing at high levels. All right, assessment, insidious onset of tibial tuberosity, pain, and aggravated by activities that cause quadriceps contraction. That's the main thing you have to get. The pain may be intermittent to start, but eventually the pain becomes continuous and gets worse as the activity continues. And it's a catch-22. The person wants to keep on moving, but the more they move, the more they do their elite level sport, the worse it's going to feel. The condition is relatively easy to pick up. Enlarged tibial tuberosity, possible swelling. That's just one example I gave at the very start. Point tenderness over the tibial tuberosity, hamstrings or quads might be tight as they're trying to stabilize the area, which our body normally does when we have areas of injury. Pain is reproduced with functional tests. Have this kid jump and land and squat in your office and see what it does for them. Active range of motion and passive range of motion will likely be full range, but may cause pain when you stress and pull on that tendon. The resisted range of motion and muscle testing for the quads may result in symptoms as well, especially if you test them strongly, like really see what they can do. Neurovascular should be within normal limits. The differential diagnosis is weak. Like really, you should be able to pick this up right away, but they might have coexisting conditions. The skiffy could be there, but that'll be somebody who's usually slightly younger for this. Again, I give my fat little boy example, hasn't been too active, and then all of a sudden decides to get out and go play with their friends and causes that to happen. Osteochondritis dissecans doesn't really fit very well because there'll be lots of locking and catching, but something you want to be aware of. Patellofemoral syndromes, look for that retropatellar pain, usually not enlargement of the tibial tuberosity. And leg calviparous, usually younger. And osteomyelitis, more of an infection type issue, doesn't really fit this picture as well, but just want to put those on your radar potentially because they could be there. So special tests, you pick any test that challenges the quadricep tendon or puts pressure on the tibial tuberosity. It may result in local pain and discomfort. Diagnostic imaging is not needed, but the X-ray will show changes in the tibial tuberosity. Ultrasound may show thickening of the tendon as well. But again, you don't really need this. This is a diagnosis you can make relatively quick, and the treatment is relatively quick as well. Here is an X-ray showing an enlargement of the tibial tuberosity and some traction apophysitis. In severe cases, it can actually lead to an avulsion fracture, but that is extremely, extremely rare. General measures, conservative treatment is recommended. 100% you can work with this person in your outpatient office. Complete cessation of sporting activity for 1 to 2 weeks. That means no running, jumping. Give their body some time to actually let the bone and chondrocytes and osteoblasts start to regrow back into that area. Now, that doesn't mean they can't walk or anything like this. They could switch to a different activity, but you're trying to avoid strong quadriceps contractions in the short term. Long-term immobilization is not indicated. You might consider K-taping or a brace so they're more cognizant of the area. Neoprene braces are nice too, because even if they take a knee and it aggravates, it can give a little padding over the tibial tuberosity. Massage therapy is a great choice. Swedish instrument-assisted techniques are all going to be fantastic. Osseous mobs for areas of compensation, definitely for massage, working through those quadriceps would be key for this person. Correcting compensatory changes too in the spine and low back and into the ankle and into the hip for your mobs and manips. Electrotherapy and acupuncture has benefits. NSAIDs, maybe short-term, possibly, usually not required. Corticosteroid injections are contraindicated. They may lead to tendon weakness and delay the healing process. Surgery, extremely rare. I would give this a run of a couple, 3 weeks at least before you went into any surgical options. The rehab program is going to make sure to allow for appropriate healing time and stretch the quads and hamstrings. Can I stress it enough for you? Pun intended. Stretch the quads and hamstrings. Increase activity intensity. Graded exercise exposure as their tolerance builds up, okay? Yeah, look at those deep squats and eccentric loading because they take the most load and put it onto the patella and that infrapatellar tendon. So I would save those for later on. Patient prevention, teach the patient's parents to recognize and the patient themselves to recognize signs of the condition and progression and what they have to do to treat it. Return to activity as soon as possible may worsen condition if you come back too soon. So give them time to heal. That 1 to 2 weeks is going to seem like it's going to take forever, but if they do it, that creates a good foundation for the healing processes to continue with the body's natural abilities. Regular warm-up and exercise and stretching. Prognosis is excellent for this condition. 95% success rate with conservative care, usually self-limiting, rarely may extend into adulthood, very rarely may progress to a avulsion fracture, extremely rare. Worst prognosis with failure to follow treatment program. So again, educate, empower, gentle exercises that promote movement, and then our manual therapies can also come out there as well. But this is one of those conditions you just want to see it. You can offer a lot of benefit for these people, educate and empower. Excellent choices. So basic massage therapy setups, simple stretches that you can perform, and then eventually progressing into lunges and other type movements as well. But what am I saying here? OsGood Shlaters, excellent condition for us to see and easy for us to manage. Great little summary for us on that one as well. Thank you very much for your time, and I will see you in the next video.